आनंद जी आप हैं और कोई है?
नहीं सर, गुड इवनिंग सर, अकेले हैं अभी सर।
गुड इवनिंग। ठीक है। Good evening, sir.
Good evening, Sarji. Good evening. Good evening. देखो, I'm there on time.
Sir. So,
मैं एक बार शेयर करना चेक कर लूं क्विकली.
हाँ जी सर, जी सर. Good evening, sir. Good evening.
I will be off.
Sarji, good evening. Pratiwari, good evening.
Good evening, sir.
Good evening, Raja.
Good evening. Good evening. Sanjay ji, good evening.
Good evening. Hope you are fine.
I'm well now. Thank you. Much better. Much better.
Okay, so nice. Thanks to God. Okay,
Ji, thank you. And thank you for all your prayers and good wishes.
thank you.
Sarji, ये दिख रहा है ना full screen?
Bilkul. I'm seeing the slide.
And you can see the slides changing now?
Yes,
sir.
yes.
Yes.
Yes, it is changing. It is changing.
बढ़िया.
Tiwari sir, we can start. Time is up.
Just watching.
Sir,
You can
sir.
start.
Let us start, sir, now. DP Singh, sir, let
Yes,
us start now.
Yeah, I have already requested our dean, sir.
Yeah, you can start, DP. You can. I'm just visitor.
Oh, okay, sir. Honorable Dean, Indian College of Physicians, Dr. Kamlesh Tiwari, sir, my friend Dr. Sanjay Kumar, and our esteemed speaker, Dr. Rajadhar, sir, and all my friends who have joined us now. Good evening to everyone and welcome to today's master teacher lecture on bronchiectasis. And it's my pleasure as a course director to introduce our very distinguished speaker, Dr. Rajadhar. Dr. Dhar is a renowned pulmonologist with a wealth of experience in managing complex respiratory disorders. His expertise in bronchiectasis is well known. Mr. Anand, may I have his CV? Yes, you can enlarge it. Yeah, it's a very small size. Looks like very small here. And he is an expert in this. He has got this registry on bronchiectasis also, and he's it's very small size. Can it be larger than that?
It doesn't. It appears it is not in the PowerPoint.
Yeah, this like that.
He is directly projecting the WhatsApp message.
Mhm.
So, sir, you can read from your phone.
It's not coming up. Oh, okay. Dr. Rajadhar is an expert in this bronchiectasis. He has got this registry on this. Also, he has got lots of publications in the research papers. He has a lot of this book chapters on this. And it is always a pleasure to listen from Dr. Rajadhar. Please, over to Dr. Rajadhar. Yes. This is CB, Director and Head of Department of Pulmonology, CK Group of Hospitals, Kolkata. Director Research and Education, National Allergy Asthma Bronchitis Institute, Kolkata. And he is a Director, Asia Pacific Alliance of Control of Influenza, APACI. Director, Hermes Exams Asia, European Diploma in Respiratory Medicine. Governing body member of Indian Academy of Bronchology. Joint Secretary, Indian Academy of Allergy, this Academy of Sleep Medicine, 124 international national publication in Index Journal, more than 17 book chapters, Associate Editor for Respirology and Editorial Board of multiple other journals. and Dronacharya Award for Excellence in Continuing Medical Education in India, and Indira Gandhi Gold Medal for Outstanding Individual Achievement in Medicine, and coordinator of DNB course for lot, and lot more. It's just the brief review or brief CV of Dr. Rajadhar. Over to Rajadhar to have his lecture on bronchiectasis. Sir.
Thank you. Thank you very much, Dr. DP Singh, for those kind words. It's a big pleasure, huge pleasure for me to be speaking on the platform of the Indian College of Physicians. So the responsibility given to me today is to speak about the diagnosis and management of what was once regarded as being an orphan lung disease, which is bronchiectasis. So let me try and put things into perspective for our trainees, our young doctors who are listening in. We know that all chronic lung diseases, especially COPD and asthma, are increasing clinical problems. We have appreciated this in the case of bronchiectasis much later, but what we do know is that between 2012 and 2022, there's been a 40% increase in prevalence over these 10 years. It's been termed variously as the most neglected disease in respiratory medicine. Happily, it's no longer so, and I'll show you that. But this was what it was termed in the European Lung White Book, which came out in 2015. The reason people said that this was a neglected disease was because this was thought to be more of a symptom complex or a syndrome rather than being one disease. So it was thought to be too heterogeneous. And I'll show you why it's been regarded as being heterogeneous. And people think that this is not a real disease. So things started changing after the European registries that Dr. DP Singh spoke about started back in 2014. And then our registry started back in 2017. And then about 100 registries now throughout the world, which have looked at the heterogeneity of the disease. The other big change was what you see in front of you, which was the fact that the European Respiratory Society came out with the bronchiectasis guidelines back in 2017. That's being updated. I'm fortunate to be a part of the ERS board, which is writing up the new global guidelines for ERS. There's a representation from Asia in the way of myself. There's an African in the guideline. There's a South American in the guideline. So hopefully we'll truly have a global guideline in 2025. However, the definition of bronchiectasis was mandated as a chronic respiratory disease characterized by clinical syndrome of cough, sputum production, and bronchial infection, and radiologically by abnormal and permanent dilatation of the bronchus. Now, this sounds very simple to all of you. It's a simple definition, but understand that there are three different aspects to this. The first is the symptom bit. So cough and sputum production form the backbone of this disease. The second is microbiological, which is as per the bronchial infection. And the third is radiological, which is abnormal and permanent dilatation of the bronchus. And I want you to remember this going forward because we'll touch on the importance of this as we go along through the course of this lecture. We came out with this review article with people from various continents writing this up in Nature about 6 years ago now. I want you to see this lovely cartoon which explains the pathophysiology of bronchiectasis. So on the left of that slide, you see a normal bronchus. And in the normal bronchus, you see an inner lining, which is made up of cilia. Then there's a mucus layer. Then there's the bronchial smooth muscle. And these two are separated from each other by the basement membrane. Now, if you want to remember three important things about pathophysiology of bronchiectasis, tip for the youngsters, remember these three. The first is destruction of the inner wall of the bronchus. The third is increased formation of mucus. And the third is loss of cilia. So destruction of the wall, increased mucus production, and loss of cilia happens in various combinations. And depending on which is the predominant change, you get the various anatomical types of bronchiectasis, You can see a few of them on the right of that slide. So bronchiectasis can be cystic, it can be varicose, it can be cylindrical, and not mentioned on the slide are types like saccular. So cystic, varicose, cylindrical, and saccular are the various anatomical types of bronchiectasis. And remember the pathophysiological types: loss of cilia, increased mucus, and destruction of the wall. This is from the same Nature review paper and shows the changes in slightly greater detail. So the reason these changes come about in the airway is genetic. So the CFTR mutation in case of cystic fibrosis is given as a case example there. Or you could have increased oxidative stress, which could result from recurrent infections. And this results in dysfunctional cilia, excessive mucus production, thickening of the smooth muscle resulting in airway obstruction and sometimes dilatation. And hence recurrent infections happen, and this cascade, this circle keeps getting repeated again and again. So that's the pathophysiology, and the triggers, you see two of them there. One is genetic, the other is oxidative stress and hypoxia. So we've done a little bit about the anatomical and pathophysiological types. We said in the definition that radiological changes, HRCT changes, bronchial dilatation is a must in bronchiectasis. So I show you some photographs of CT scans, and I want you to remember these as a transition from mild bronchial wall thickening to bronchial dilatation and florid bronchiectasis and its complications. So I'll show you a sequence of slides. Try and remember this in this sequence. So in this slide, I don't know whether you can see my cursor or not, but what you see on there is a dilated thickened bronchus. So this tapering wall of the bronchus that you see in the right lung on there is a dilated bronchus. The next one you see multiple dilated bronchi there. You can see them in the perihilar region. You can see them in the periphery, and you can see ground glass opacities within the lung. This is one step forward. This can be termed as early bronchiectasis, especially if these patients have cough and sputum production. As you move forward, you now see florid areas of cystic and saccular bronchiectasis. And you can see them in both the right and the left lung, albeit there's more in the right than in the left lung. And you see small areas of consolidation and areas of mucus plugging. The next section that you see now has more florid mucus plugging. You have areas of ground glass opacities. You have airways which are filled up with mucus. So now it's bilateral, significant bronchiectasis, and the shape, the anatomical variants of bronchiectasis here are cystic, there's saccular, and cylindrical bronchiectasis. Even more florid changes, you can see now branching bronchi, you can see mucus-filled bronchus, you can see small areas of consolidation, and you can see ground glass opacities. And then as we go forward, you see the complications coming in. So you see these dilated saccular areas of bronchiectasis, and within them, you see small ball-like structures, crescents. These are early appearances of fungal balls and aspergillomas. And on this, you see a large aspergilloma. So you saw the transition starting from one or two areas of bronchial thickening to unilateral changes but multiple lobes, to bilateral changes, to mucus plugs, to formation of thick mucus, viscid mucus, hyperattenuating mucus in the airways, to formation of aspergillomas, and then large aspergillomas, which might result in significant hemoptysis as a complication of bronchiectasis. So that's the radiological transition. Those are the changes that you see in patients with bronchiectasis. These, remember, need to be accompanied by symptoms of bronchiectasis. So this was a lovely study that we published about 8 years ago in the European Respiratory Journal, where we spoke to about 800 patients across India and Europe, and we numbered the aspects of bronchiectasis that were found to be difficult to control, difficult to handle by patients. So sputum production exacerbations are the most important. And why do I say this? How is this important for all our students listening in today? This is important because when you target treatment in bronchiectasis, what you try and do is to reduce sputum volume, reduce colonization by bugs which are gram-negative, so bugs like Pseudomonas and Klebsiella in the sputum, and you try and prevent exacerbations. So sputum and exacerbations are the hallmark, the most important factors in bronchiectasis as far as the patient is concerned. Then you get systemic features. What are these systemic features? You get tiredness, you don't feel well enough to do your day-to-day activities. Those are the next most common and systemic features, and you get this due to systemic inflammation. And I'll come back to what systemic inflammation in bronchiectasis entails and how it's different to asthma in a few moments. Then you get symptoms like cough. The cough often disturbs sleep, so sleeping problems. Chronic respiratory disease results in anxiety, depression, and other psychological factors, so that comes next. The exacerbations sometimes are severe enough to mandate hospital admission, that comes next. And then you have other symptoms. But I want you to remember the top ones. What's important for the patient? Sputum and exacerbations, systemic features like tiredness, not being able to do day-to-day activities, and then breathlessness, cough, etc. Those are the symptoms which are important for patients. How would you diagnose bronchiectasis? And this is important. I want you to remember this. And if you get a question on bronchiectasis where the diagnosis is important, put it as it has been put in this slide. So there are two ways in which you can diagnose bronchiectasis. The first is when you have the clinical features, the clinical symptoms of bronchiectasis. And the second is when you've done a CT thorax for some other reason and you pick up bronchiectasis incidentally. So let's start off with the incidental evidence of bronchiectasis on CT. So incidental evidence of bronchiectasis on CT is dependent on 4 radiological criteria. And I want you to remember this. This is important for the exams. So guys, try and remember this. So inner airway diameter divided minus the artery ratio is greater than 1. So inner artery airway diameter divided by the artery ratio is greater than 1. Outer airway diameter by the artery ratio is greater than 1. Lack of tapering of the airway. So the airway remains parallel to each other, doesn't taper downwards. And fourth, visibility of airways in the peripheral third of the visible lung on CT. So the airway diameter by the artery ratio, outer or inner, lack of tapering, and visibility of airway in the periphery are the things to remember. If you have these features, you ask the patient whether they have the symptoms of bronchiectasis and what they may be. Remember the definition, it's cough most days of the week, sputum production most days of the week, a history of exacerbations. So if you have all of these features, or at least 2 of these features, along with the CT features we described, then your patient has clinically significant bronchiectasis. If there are no symptoms, not even 2 of them, then the patient has radiological evidence of bronchiectasis, but no clinical significant disease. So remember these 2 categories: radiological evidence without symptoms, radiological features with symptoms. The second category is when the patient comes to you with symptoms of bronchiectasis. So cough most days of the week, like we said, sputum production most days of the week, and a history of exacerbations. If the patient has these, you do a CT and look for the features of CT that we described. So the inner airway diameter by the artery ratio, outer airway diameter by the artery ratio, lack of tapering, visibility of airways in the periphery. If your patient has these, then again, this patient has clinically significant bronchiectasis. If the patient does not have these, then the patient does not have bronchiectasis, because symptoms are essential for bronchiectasis, even more than the radiology. And then there's a new terminology which has been put in for patients who have symptoms of bronchiectasis, but no CT changes. This is called protracted bacterial bronchitis. And for our young trainees, young doctors today, this is a terminology you want to remember, because it's thought that if you manage to diagnose PBB, which is protracted bacterial bronchitis, you can actually prevent the onset of bronchiectasis. I'll say this again because it's important and futuristic. So if you diagnose people with clinical symptoms of bronchiectasis without the CT findings that we have described, then this condition is called protracted bacterial bronchitis or PBB, where starting treatment might mean that you prevent the onset of radiological bronchiectasis in these patients. This is a small slide. I love this slide because it's very simplistically tells you about what we in our young age thought about obstructive airways disease. So we learned that obstructive airways disease were of three types: asthma, COPD, and bronchiectasis. We now know that bronchiectasis can be an obstructive or a restrictive disease, and I'll come back to this. But just important points on that slide. Bronchiectasis is a lower prevalence, less than 0.5% of the population, even in India. CT features need to be there. Symptoms need to be there. COPD, as you know, has a much larger prevalence. It's 7 to 10%. In India, it's about 6.2% in 2023 as the global burden of disease data. There has to be an exposure, which could be tobacco, which could be biomass fuel, which could be your incense sticks, etc. There are symptoms, and the spirometry shows an obstructive airflow limitation, similar to what shows on the flow volume loop there for you. And then the asthma, which has a variable prevalence throughout the world. In India, it's about 4.5%. There are symptoms, and this variable airflow obstruction rather than the fixed airflow obstruction of COPD. So compartmentalize these three in your head: bronchiectasis, COPD, and asthma. So this is putting some of the EMBARK data into perspective. So this is the European Multicentric Bronchiectasis Registry. There's the Indian registry, I'll show you in a minute. But this is the European registry, and I have put this up for certain very important carry-home messages for all of you. First, the most important marker for prognosis of disease in bronchiectasis is exacerbations. And greater the number of exacerbations, greater the mortality in this disease. I want you to look at the top left graph, and I want you to see the red line. The red line is made up of patients who've had 3 or more exacerbations in a given year. And you can see that at 5 years, the mortality for this population is greater than 20%. Compare that with patients who have 1 exacerbation in a given year, and you can see there the mortality is less than 5%. So less than 5% for 1 exacerbation a year, 20% mortality at 5 years for people who have 3 or more exacerbations in a given year. That's how important exacerbations are. Exacerbations are dictated by colonization with bacteria. Look at the top bottom bit where you see the various bugs, and you can see across the globe. I'll show you Indian data in a moment, but across the globe, the most important bug is Pseudomonas aeruginosa. And if you colonize by Pseudomonas aeruginosa, if you grow Pseudomonas aeruginosa even once, then the mortality over 4 years is above 20%. Compare with this with the non-Pseudomonas population, where the mortality is less than 5%. So Pseudomonas is a marker for mortality, and so is exacerbations. The next table that you see, which says severity marker endpoints, is what is called the Bronchiectasis Severity Index, or the BSI, Bronchiectasis Severity Index, or BSI. And you can see it's made up of various parameters. I won't go through this, but please read this. And if you can, score your patients with bronchiectasis. These are easy to score. It's mandated by 7 different parameters: age, BMI, FEV1, hospital admissions, MMRC score, Pseudomonas colonization, and the number of lobes involved due to bronchiectasis. Those are the markers, and depending on your score, you can have a mild, a moderate, and a severe BSI. A mild, moderate, and severe BSI. And again, similar to what you saw with exacerbations, you can see the red line at the bottom. If you belong to the severe category of bronchiectasis severity index, then your chances of dying on follow-up is far greater as compared to having a mild BSI. So BSI again helps you to prognosticate patients. So again, 3 things to remember when you treat patients with bronchiectasis. What are the 3 parameters that you're trying to achieve? Remember what was important for the patient. It was important for the patient. Exacerbations were important for the patient. So you need to prevent exacerbations. Cough, sputum production was important for the patients. That happens due to airway infection. So you need to control airway infections. Quality of life is important for the patients. So you optimize functional status. So 3 endpoints targets: prevent exacerbations, control airway infection, and optimize the functional status in patients. Let me tell you a little bit about the Indian data and compare it with data from throughout the world. This is the registry data we spoke about. This is a paper from the Lancet, which Dr. Singh was kind enough to mention in the beginning, which we published back in 2019. Multiple centers, 31 centers, 2,195 patients. And we found that post-TB bronchiectasis was the commonest etiology of bronchiectasis in India. Post-TB bronchiectasis constituted more than 35% of our patients with bronchiectasis. Why is etiology important? You might ask me that question. Why is etiology important? Why am I talking about etiology of bronchiectasis? That is why, because there are certain etiologies of bronchiectasis, and the list is there in front of you, where treating the etiological cause of bronchiectasis changes or improves the course of disease. So treating the etiology improves the prognosis, improves disease outcomes. So what are these treatable causes? It is combined variable immunodeficiency, there's allergic bronchopulmonary aspergillosis, which is important, a common cause of bronchiectasis in India. There's mycobacterial infections, there's airways obstruction, there's inflammatory bowel disease, there's rheumatoid arthritis, and there's aspiration. So these 7 etiologies, treating the etiology improves disease outcomes in these individuals. This is the comparison of clinical cohorts from 4 countries, well, countries and continents actually. So there's Korea, there's Australia, there's Europe, and there's India. And I want you to look at the comparison and what's different in India compared to other continents. Again, important for your exams. First, the age of patients to have bronchiectasis in this country is younger by a decade. So we get patients who are younger by a decade with the mean age being 56 years. India is the only country in the world where bronchiectasis is more common in men as compared to women. So 56% of men in India have bronchiectasis, 44% of women have bronchiectasis. And if you look at Korea, Australia, Europe, you can see that women outnumber men significantly. We have the poorest BMI. So the thinnest patients with bronchiectasis, the most nutritionally deprived, the ones with most number of complications are from India. I want you to look at the next red arrow right at the bottom, which looks at severe BSI. You remember we classed BSI as mild, moderate, and severe. So this most severe BSI is actually not from India, but from Australia. However, if you look at the MMRC dyspnea score and the hospitalizations in the previous year, India outscores the other areas of the world. Especially hospitalizations are the highest by far in India. So it's less severe, but more hospitalization. It shows the heterogeneity of hospitalized care in the country more than severity of the disease. Microbiology is very important. Pseudomonas is the commonest bug in India. However, in India, you get a lot of Klebsiella under the umbrella of Enterobacteriaceae. You get Klebsiella and you get E. coli, and these bugs are important. So Pseudomonas and Klebsiella are the important bugs in India. This compares etiology, and the etiology is similar in that the commonest etiologies are infective, idiopathic. In India, the infection that's commonest is TB, but you see a similarity in the first 3 across the various countries and continents there. And another similarity right at the bottom, that the 2 evidence-based treatments we have, and we'll come back to this, inhaled antibiotics and long-term antibiotics are poorly used throughout the world. So inhaled antibiotics and long-term antibiotics in the way of low-dose macrolides is poorly used throughout the world. I want you to remember this comparison going forward because it's important when we try and identify the gaps in research, the gaps in knowledge in bronchiectasis. So this is what we were saying. Remember when we compared asthma, COPD, and bronchiectasis, Bronchiectasis is not a conventional obstructive airways disease like asthma and COPD. However, unfortunately, in our registry, more than 60% of our patients were receiving inhaled corticosteroid, which I'll show you in a moment, is actually injurious for most of these patients. And about 55% or more of these patients were on a LABA and an ICS, similar to what you would do in an asthmatic or even someone with COPD. So we don't treat our patients right. We treat them like any other obstructive airways disease. N-acetylcysteine was the most commonly used mucoactive drug, and this is good. There's indication to do so. However, again, not so good. We treat our patients like asthma, COPD. They get prescribed theophylline, leukotriene receptor antagonists, etc. in large numbers. The next thing is about the evidence-based treatment I spoke about. You can see the number of patients being treated with low-dose macrolides, long-term oral antibiotics or inhaled antibiotics is minuscule. It's less than 5% overall in these patients. So quality of treatment leaves a lot to be desired, and we need to remember what the evidence-based treatment for bronchiectasis is. This is our follow-up paper. So we followed these patients that I showed you in a moment ago, over a 4.5-year period. And we then published our findings in 2023. And I want you to show 2 or 3 slides from the findings. And these are, again, very important from an exam perspective. So what are the important predictors of mortality? The important predictors of mortality in India are age above 65 years, Enterobacteriaceae infection, especially with Klebsiella, exacerbations of more than 2 or more than 1 hospitalized exacerbation, cardiovascular disease, diabetes, and MRC dyspnea score of more than 2, and current smoking increase the risk of mortality in these patients. And please remember the list, especially the Enterobacteriaceae infection and the exacerbations, which are the most prominent in increasing mortality. What are the worst diseases to have? What etiological causes of bronchiectasis causes the most number of deaths? So mortality is highest in the bronchiectasis COPD overlap group. Hospitalizations are the highest in the bronchiectasis COPD overlap groups. That's important because of bronchiectasis COPD overlap syndrome has the highest mortality, has the highest number of hospitalizations. Another etiology, which is important to remember from a poor prognosis perspective, is rheumatoid arthritis associated bronchiectasis. So rheumatoid arthritis associated bronchiectasis also causes a significant amount of mortality. The numbers are small, but the mortality is high. The bronchiectasis with the best prognosis is asthma bronchiectasis overlap. So asthma bronchiectasis overlap, not ABPA, but asthma bronchiectasis overlap has the best prognosis out of all etiologies of bronchiectasis. This shows you the predictors of exacerbations. You saw the predictors of mortality a little while ago. The predictors of exacerbation are similar. So prior exacerbation, Pseudomonas infection, diabetes, smoking, and an increased MMRC score are important. The one to remember here is Pseudomonas. You saw mortality was mandated by Klebsiella. Exacerbations seem to be triggered more by Pseudomonas. So all of these gram-negative bugs are bad for you. Thankfully, bronchiectasis does not cause a lot of mortality in our country, similar to Europe. The mortality was low at 4.5 years. You can see the mortality in the Indian population is slightly greater as compared to the European. The Indian population is in red, the European is in blue, slightly greater mortality in the Indian population of patients. However, this was not significant in on statistical analysis. Let's now get into a little bit of pathophysiology, and I'm sort of in the past the halfway mark, so I'll finish the talk in about 15 minutes, and hopefully we'll be able to take some questions. So this is called, on the left, the circle that you see is called the vicious vortex of bronchiectasis. It's called the vicious vortex of bronchiectasis. So you can see all of these circles are interconnected with each other, which means that it doesn't really go in the circle that I have shown. It can go in any direction from one to the other. Let's start with the red circle. The inflammation in bronchiectasis that I've been speaking about, unlike asthma, is neutrophilic inflammation. Remember this, guys. The inflammation in bronchiectasis is neutrophilic inflammation. You know the inflammation in asthma is eosinophilic inflammation. So neutrophilic inflammation results in a lot of T cells coming into the area of inflammation, and it's aggravated by local or systemic immunodeficiency. The immunodeficiency and the neutrophilic inflammation results in chronic bacterial infection. Chronic bacterial infection recurrently results in bronchiectasis due to lung destruction, and this results in ciliary dysfunction, lots of mucus secretion, epithelial dysfunction, and this vicious vortex goes round and round, but also across from each other. So remember these four: mucus hypersecretion and ciliary dysfunction, neutrophilic inflammation, chronic inflammation, lung destruction causing bronchiectasis are the four parameters to remember. I show you some proof of concept studies which are very important to understand this neutrophilic inflammation I spoke about. See the graph in the middle which says PA and non-PA. That's the graph to look at. So this is the cluster diagram. The black dots are people who have never grown Pseudomonas, and the green dots are ones who've grown Pseudomonas at least once or more than that. So if you look at the green dots, they're clustered together. The black dots are clustered together. So when these patients were identified and followed over a period of time, it was found that the ones who've grown Pseudomonas have more of neutrophil elastase. So what is neutrophil elastase? Neutrophil elastase is an enzyme that drives neutrophilic inflammation, causes lung destruction, and causes bronchiectasis. So patients with Pseudomonas had a higher level of neutrophil elastase, as compared to patients who did not have Pseudomonas aeruginosa. I'll say this again. Please remember this. Patients with Pseudomonas aeruginosa had a higher level of neutrophil elastase, hence more lung destruction, more exacerbations, more vicious vortex of bronchiectasis, and hence greater mortality from bronchiectasis. So let's hold this thought, neutrophilic inflammation and neutrophil elastase, and quickly look at some questions that have been posed in the ERS guidelines for the management of bronchiectasis. I'll be quick with this because I've said most of this before. So before that, let's look at the current treatment. So the four arms in the management of bronchiectasis is diagnosis based on HRCT, which we have talked about. Potentially treatable causes of bronchiectasis, which we have talked about. These are etiologies where there is treatment which changes the prognosis of bronchiectasis. Then there's lung function, which we have talked about. And then this microbiology we've talked about. We also need to talk about comorbidities. We mentioned this, remember. People with diabetes, people with heart disease have a poor prognosis. So comorbidities assessment and control is important. And then you assess the severity based on the bronchiectasis severity index, and you look at clinical phenotypes. The 5 verticals in the management are treatment of the cause, which depends on the cause, obviously. Improve chest clearance. So you do this by physiotherapy and rehabilitation along with mucoactive treatment. Of course, you need to ask people to stop smoking, but smoking is less in patients with bronchiectasis. There's control of infection. So you eradicate infection by means of antibiotic therapy. You control lung function with means of bronchodilators when the patients are breathless or when there's bronchoconstriction. And you control complications like hemoptysis by things like embolization. In end-stage lung disease, you could think of transplant, but transplant is a lesser used modality in patients with bronchiectasis as compared to ILD and COPD. So transplant is lower down on that list in patients with bronchiectasis. And then you give them a self-management plan. And the reason you give them a self-management plan is 3 factors. 1, you want to improve their quality of life. 2nd, you want to reduce exacerbations and hospitalization. And 3rd, you want to reduce mortality in these patients with bronchiectasis. So remember this lovely diagram from the ERS guideline. This overall outlines the management of bronchiectasis for you. So what do you do with people who exacerbate recurrently? So people with 3 or more exacerbations in a given year, you need to optimize their chest physiotherapy, the airway clearance. And there are two modalities available to you. One, you give them an inhaled antibiotic. If they are growing Pseudomonas, the inhaled antibiotics available in our country are inhaled tobramycin and inhaled colistin. And if they're not growing Pseudomonas, you give them a long-term macrolide. So azithromycin at 250 or 500 milligram, 3 times a week. Both of these treatments ideally should be continued for a period of 1 year. If you have used one but failed to control, you can add in the other one, or you can change to the other one. You can do both. So inhaled antibiotics on one side, long-term macrolides on the other. I'll skip a few slides for the want of time, and let me go to one of the concluding slides that I have. This is from 2022, a large meta-analysis which came up with something I really love. So I've put up the slide verbatim. So macrolides, azithromycin, the way I told you, works the best in patients with bronchiectasis. They appear superior to any other treatment we currently have for bronchiectasis in reducing exacerbations. Inhaled antibiotics work, but the higher the bacterial load, the greater the response with inhaled antibiotics. And there are new therapies which I'll speak about in a moment. So the future, quickly. So I spoke about neutrophil elastase. I said the greater the amount of neutrophil elastase, the greater the lung destruction, the greater the lung destruction, the greater the morbidity and mortality with the disease. About 20% of patients with bronchiectasis have a eosinophilic inflammation similar to asthma. So similar to asthma, these are patients who would respond to inhaled corticosteroids. So remember our registry, we said 63% of patients were prescribed inhaled corticosteroid. In the European data, there's only 20% of patients who have a raised eosinophil. So an absolute eosinophil count of more than 300. And these are the only ones which benefit. The others have a chance of getting greater number of infections if you give them inhaled corticosteroids. So this is the algorithmic approach I want you to remember. Phenotyping of patients, what do you do? So you have someone with frequent bronchiectasis exacerbations. In all these patients, you need to do airway clearance techniques and treat the underlying condition. After this, you have two options. You can either give them a macrolide, or if there's a lot of phlegm, there's stickiness at the back of the throat, you can prescribe them a 3% or a 7% hypertonic saline, loosen the phlegm, and then use the airway clearance devices and techniques that we have not spoken about in great detail today. Then you classify them after the macrolides to 3 categories. When there's increased bacterial load, you give them inhaled antibiotics, so a tobramycin or a colistin. When there's sputum plugging, you give them hypertonic saline or other mucoactive agents. When there's eosinophil inflammation, you give them inhaled corticosteroids. So now quickly questions and answers. These are questions straight for the exams, and I want you to remember them. They are from the guidelines. So what investigations should be performed in patients with bronchiectasis to determine underlying cause? So the guidelines as of today say that you have to do a white cell count and look at the eosinophil count. You need to do immunoglobulins. You need to screen these patients for ABPA. And the test that you need to do in this category is a total IG and a specific IG for Aspergillus. And then, depending on what you find, you select further investigations for your patients. So circulating white cell count, especially the eosinophil count, immunoglobulin, screening for ABPA in the way of total IgE and specific IG. These are the clinical phenotypes and the investigations. I'll leave this slide with you guys so you can have this slide, look at it in your own time. I don't have time to go through, but obviously the symptoms these patients have, the age they have, the sex they are, the radiological features they have will mandate how you phenotype these patients and what investigations you do in them. Second question is, how long do you treat for an acute exacerbation of bronchiectasis? These patients should be treated for 2 weeks with oral antibiotics, 2 weeks with oral, and if it's severe, intravenous antibiotics. Should we attempt to eradicate pathogenic organisms? And the literature here says you should try and eradicate the pathogenic organisms. You should use antibiotics, both nebulized, oral, and IV. Eradicating the organism reduces future exacerbations in these patients. Question 4. Should long-term anti-inflammatory treatment be used for patients with bronchiectasis? So this is a no. So only in a select few patients would you use inhaled corticosteroids in these patients. You don't give them statins and anti-inflammatory. There's no evidence. And once you have an overlap of asthma or COPD with bronchiectasis, you can use the asthma or the COPD guideline to prescribe them inhaled steroids if required. Question 5. Long-term antibiotic treatment compared to no treatment for treating adult bronchiectasis patients. So there's a lot of data which shows that treating patients with long-term low-dose macrolides reduces exacerbations in patients with bronchiectasis. So answer to that question is yes, you should use long-term antibiotics for more than 3 months in the treatment of exacerbating phenotype of bronchiectasis. Is mucoactive treatment. That's why we spoke about N-acetylcysteine. There's also carbocysteine. So are these useful compared to no treatment in adult patients? The answer is yes. Mucoactive treatment does help in reducing sputum volume and reducing exacerbations in patients with bronchiectasis. Question 7. What about long-term bronchodilator treatment? So long-term bronchodilator treatment should only be used in patients who have significant breathlessness on an individual basis, not the 56% patients that we found in the EMBARK India registry. Question 8. Are there surgical interventions more beneficial compared to standard treatment for adult bronchiectasis? The recommendation says that surgical treatment for adult patients should be used in exceptional circumstances. Hemoptysis, where bronchiectasis is localized to one segment or one lobe, you can use lobectomy or segmentectomy, but it's only in a very small minority of patients that you use surgery. And last, is regular physiotherapy useful? And the answer is a big yes. Every patient of bronchiectasis should have regular physiotherapy, and that forms the backbone, it forms the spine of treatment of patients with bronchiectasis. In the last minute, new therapies. So there's just an exciting news in bronchiectasis from globally, which is the success of this new drug called brensocatib. And what is brensocatib? You know this now. It inhibits neutrophil elastase or DPP1. So the agent which caused lung destruction, if you inhibit neutrophilic inflammation using brensocatib, it reduces the inflammatory load and reduces exacerbations in patients with bronchiectasis. So I'll finish off here. That's the concluding slide. A lot of heterogeneity in the disease process is something that I've shown all of you. I've shown you the ERS guidelines, other similar guidelines which are there. The ERS revised guideline will come up this year, and we will have updated information on and guidance on management of this disease. Better clinical care mandates airway clearance, inhaled antibiotics, low-dose macrolides, and patient risk assessment. The registries that we have now globally are very important in characterizing disease and hence categorizing the importance of various agents in management. We need to understand the various etiologies and the nature of inflammation, neutrophilic versus eosinophilic in bronchiectasis, and then targeted therapy. Neutrophilic inflammation targeted by brensocatib, for instance, is the way forward. And important that all of us join hands in generating data in India, more data, good data, so that we treat the patients with bronchiectasis better. Thank you very much for listening.
So I would request PGs and other friends to put up questions on the chat box. Dr. Sanjay ji to take up the questions, and Dr. Sanjay Kumar.
There is one question regarding the steroid. Steroids will be beneficial or worsen the condition in patients with tuberculosis along with bronchiectasis?
So that's a very good question. Sanjay Bhai, as you know, these patients have post-TB bronchiectasis. So the population of more than 35% of patients that we had with bronchiectasis were post-TB, and there was a very small minority of patients who had active tuberculosis. Now, even in the post-TB category of patients, the inflammation is mainly neutrophilic. And hence, giving these patients inhaled corticosteroid increases the risk of not just the TB recurring, but also other infections recurring, which is why I've tried to sort of underline repeatedly through the course of my talk that use steroid judiciously. It is only for a small minority of patients with bronchiectasis.
Thank you. There is another question that is regarding a patient who comes with a history of chronic shortness of breath and cough. Can it be differentiated on the history if the patient has either COPD, bronchiectasis, ILD, or something like OSA?
A lovely question. So let's think about this. I'll take a couple of minutes to answer this actually, because I think this is a very, very important, intelligent, and relevant question. So the cough in bronchiectasis, because it produces sputum, is a wet cough. It's a rattly cough. It produces phlegm. You get a similar cough in patients with chronic bronchitis, which is one of the traditional phenotypes of COPD. So it's difficult to distinguish between bronchiectasis history and chronic bronchitis history just based on the history itself. However, if you listen to the chest of a patient with bronchiectasis, you're likely to hear crackles. These crackles are more prominent in the lower lobes. However, you can get bronchiectasis anywhere, and in post-TB, you would actually get it in the upper lobes. In patients with chronic bronchitis, because it's an airway disease, if you listen to the chest, you hear wheeze. So that's an easy way of distinguishing between patients who have chronic bronchitis and bronchiectasis. Now, what about the emphysema phenotype? What about interstitial lung disease? So interstitial lung disease is relatively easy. The cough in interstitial lung disease is classic. It's a very dry cough. It comes from the sort of base of the chest. It comes from low, but it's never fruity. It's never wet. It's a very dry cough. And when you listen to the chest of these patients, you will hear crackles, again, mostly at the bases. But these are leathery crackles. They are in both inspiration and expiration. And you hear these very dry, what's been described as Velcro crackles, which are very, very relevant in the diagnosis of interstitial lung disease. The crackles of bronchiectasis are different. So get your patient with chronic respiratory disease to cough. Often you would be able to tell apart bronchiectasis from interstitial lung disease just by getting these patients to cough and listening to the sound of the cough. Obstructive sleep apnea, however, is a different beast. Here, your patient normally has the phenotype. They are big, bulky, they hardly have any neck, they have daytime somnolence, etc. The problem arises when there is an overlap of obstructive sleep apnea with one of the chronic respiratory diseases, which happens often. And here, because these patients are obese, it's difficult to hear the crackles. These people are not energetic. They have breathlessness because of their obesity. Whether they have breathlessness due to underlying ILD is difficult to decipher. So obesity and OSA and a chronic respiratory disease overlap are diagnoses which are difficult to distinguish in people. We're left with emphysema. So emphysema results in a very quiet chest and a relatively dry cough. The patients look like ones with bronchiectasis, and being cachectic, they have weight loss, they have hardly any flesh. However, in bronchiectasis, like we said, you would hear the wet crackles on auscultation of the chest. They would have a fruity cough, whereas the patients with emphysema will have reduced air entry. You would auscultate and hear a very quiet chest in these patients. So answer to your question, that was a long answer, I'm sorry, but I think it's important to take a history. It's important to get the patients to cough, and it's important to auscultate these patients, and then you can have a fair idea about which chronic respiratory disease you're dealing with.
There is another question from Dr. Neha Kumari.
Right.
DPP-1 inhibitor, whether it will be useful in both CF or non-CF?
Yeah, that's a great question. So, Dr. Neha Kumari, that's a very good question. So the management of CF has evolved to an extent that we have found cure for genetic diseases. Genetic disease as in CF. It is based on the mutation in that particular individual. In patients with non-CF bronchiectasis, unfortunately, I skipped that slide actually. There's still a lot of genetic changes in non-CF bronchiectasis. However, the treatment is now being based on combating neutrophilic inflammation. We are still finding out information about the genetic modifications that happen in non-CF bronchiectasis. So we don't use DPP1 inhibitors in CF because they're better drugs. However, going forward, the future of bronchiectasis would also be based on patients with genetic forms of bronchiectasis, non-CF bronchiectasis, with being treated with drugs similar to CF and not the other way around.
Dr. Sanjay.
Yeah. So it was very nice. So there is one question regarding the NAC therapy. How long it should be continued? Is it to be given lifelong?
Yeah, so NAC is a safe drug, Sanjay Bhai. It's a safe drug. It's an easy drug to use, and it should be used in people who have very thick, tenacious sputum. Normally, so the trials that there are all over 1 year. So they are 1 year therapy. What do I do in my clinical practice? I would use them for a period of 2 to 3 months, maybe a maximum of 4 months. Once I get the chest clear in these individuals, I would continue with the chest physiotherapy with their OPEP devices like aerobica or acapella. However, I would stop the NAC for a period of time and then restart it again when the sputum starts becoming tenacious again. I wouldn't give this drug continuously, lifelong, even if it does not cause a lot of side effects, because I don't think that causes a lot of benefit. However, it should be given at intervals of 2 to 4 months and then stop for some time and then restart it again.
There is one question from my side.
Yes.
I just request you to share your experience about aerobica.
So very good experience. I use it very often, to be honest with you, Sanjay Bhai. I am a proponent. So there's a few things to remember about aerobica. So aerobica is for patients who produce phlegm but cannot remove all of it from their chest on a day-to-day basis. The OPEP devices, of which aerobica is probably the most important and the most evidence-based we have in the country today, causes agitation of the phlegm within the airway. It breaks the phlegm down into smaller pieces and it helps expectorate the phlegm. Before using aerobica, it's useful to use a mucoactive agent like a carbocystin, like a NAC, like a hypotonic saline to reduce the viscosity of the sputum so that it becomes easy to bring up the phlegm in these individuals. Never use it in a patient who's having active hemoptysis. Never use it at the beginning of an exacerbation. Use it later on in the course, because using an OPEP device or a positive pressure device can actually worsen the airway narrowing in these people if they have airway narrowing or bronchospasm. So those are the two precautions. Don't use it in the beginning of an exacerbation. Don't use it in patients with a hemoptysis. Very efficacious agent. I personally use it very often and have a lot of faith in OPEP devices, especially aerobica.
And do you have any experience of chest vibrator jackets?
I do. So again, we have access to, because we are a bronchiectasis center with my experience in Embark, we do use the vibrating jackets, but I think these are expensive devices. They can only be used in centers where you have a dedicated bronchiectasis clinic. And most patients would benefit from a mucoactive agent with an OPEP device and will not have to access a vibrating device. These vibrating devices are patients who have very thick viscid mucus where the pores of Kohn, etc. get plugged with these viscid secretions. In these individuals, it's useful using a vibrating jacket, but I probably use it in about 2 or 3 patients a month. Not a huge use even today in my clinic where I have a lot of patients with bronchiectasis.
There is one question from our chairman, API, Dr. P.K. Agrawal. Management protocol difference in predominantly obstructive bronchiectasis versus restrictive bronchiectasis.
Yeah, that's a very nice question. Thank you, Dr. Agarwal. So I didn't speak about this because of lack of time. So we found something very interesting. We found that patients with post-TB bronchiectasis have a restrictive spirometry. They have a low FVC and they have a restrictive spirometry with potentially small lungs. Patients with a COPD asthma overlap with bronchiectasis. So COPD overlap with bronchiectasis, the so-called BCOS syndrome, or the asthma overlap with bronchiectasis, including ABPA, who have a predominantly obstructive spirometry, benefit with inhaled corticosteroids and bronchodilators because you're treating their airway narrowing and airway inflammation by giving them inhaled ICS, LABA, and/or LAMA. Patients with a restrictive spirometry, especially the post-TB bronchiectasis ones, don't really benefit from inhaled agents. Here, the treatment is based on active cycle breathing therapy, chest physiotherapy, the PEP and OPEP devices, treating the repeated infections with Pseudomonas, with inhaled antibiotics and low-dose macrolides, and the other treatment measures that I spoke about a little while ago. There's a trial using brensocatib in post-TB bronchiectasis from our center just now. We'll hear the results. But inhalers, especially inhaled corticosteroids and LABA, not required in patients with restrictive spirometry, required in patients with obstructive spirometry, is the most important difference I would speak about.
So we have finished the time, and I say this is the one of the best lecture on bronchiectasis that I can say that I have heard from you. And I request our PG
As usual from the Raja.
as usual from Dr. Raja. Yes, of course. And I would
Thank you.
request our PGs and other who are listening to his talk, please give his response on the WhatsApp group, our short course, certificate course on respiratory disease, that how did they like Dr. Raja's lecture on bronchiectasis. I can say fantastic, superb, unmatched, I can say. And if you request, we can again listen from him for another lecture in the coming course. That is, I say, if you request, those listening his lecture, I would request him to again give lectures on another different topics in respiratory medicine. Thank you, Dr. Raja, for this.
Thank you very much, and thank you for having me.
Reaching evening, and we thank you very much.
Thank you, Dr. Raja. Thank you.
Thank you, Dr. Sanjay Kumar. Thank you, Dr. DP Singh. Obliged. Thank you.
Thank you.
So the session is closed, and Sanjay ji, everything okay?
Yes, sir. Sir, one thing just I want to say, if the students wish, they can put questions in the WhatsApp group so that we can forward to the speakers for their answers.
All the speakers are there in the group. We have joined all the speakers. Still this Dr. Deepak Talwar, Dr. Agam, Dr. Raja, all are in our group. So they can answer the questions.
So I just want to take a liberty from the speakers that students may put some questions to them if they are not able to ask here. So they can put directly to him and he may answer the questions.
Yes, yes. But this is the complete, I say, lecture from Dr. Raja, because he has already put up the objective questions. They have given the answers, are very standard questions. And this is the fantastic session, I think. Thank you, Dr. Sanjay, and Thanks all our
Thank you, sir. Thank you, sir.